Okay, we are live, so we can start.
Okay, thanks, Ashok. So, good afternoon, everybody. Welcome to today's webinar where we have Dr. Arvind Gupta, who's going to tell us about acromioclavicular injuries. Uh, as we all know that the acromioclavicular joint dislocation is one of the controversial areas in orthopedics, and the treatment varies from doing very major surgery to doing type 1 and type 2 injuries can all be managed conservatively, while in type 3, there's still some controversy, and maybe in the sporting individual or people involved in heavy labor, there may be some indications for surgery. Also, there are newer techniques of surgery which may make it a little more predictable in terms of its results. So I think I will hand it over to Dr. Arvind Gupta, who's going to try and clarify these various doubts that people may have in their mind when it comes to dealing with these acromioclavicular joint injuries. Arvind.
Thank you, sir. May I start sharing? Good evening, everyone. Today I'll discuss AC joint injury. What are the challenges and what are the recent advancements? So let's start with the anatomy. Anatomy is formed by the lateral end of the clavicle, acromion, the surrounding capsule, and there are ligaments around this joint as well as the muscles. This joint is diorthoidal joint with inclination vary from 10 degree to 50 degree with the intra-articular disc, which usually start getting degenerated after 40 years. And the clavicular articular surface is smaller than the acromial facet. About the ligament, the first is the AC ligament. AC ligament prevents the horizontal displacement of the clavicle in the direction of anterior and the posterior direction. The main constraint provided by the superior AC ligament and followed by the posterior AC ligament. And there is acromial ligament also there around this joint, but usually don't play any significant role in AC joint stability. Next is the CC ligament. It prevents the vertical displacement of the clavicle, at the same time having secondary prevention in the horizontal displacement also. Having two ligaments, one is the trapezoid, another is the conoid. Trapezoid attaches over the anterolateral side of the clavicle and the conoid attaches over the posterolateral side of the posteromedial side of the clavicle. About the attachment in millimeter, the average around 25 millimeter from the lateral end of the clavicle, trapezoid part get attached, and the conoid part is around 45 millimeter average. The anatomy of coracoid should also be kept in mind while dealing with AC joint injury, because for the treatment part, we have to make a hole, sometimes make a hole in the coracoid. So coracoid base is taken as the maximum width, having around 25 millimeter average. So whenever we have to make a drill in the coracoid, it should be at the base level, not in the body or tip of the coracoid. Dynamic stabilizer is formed by the muscle around this joint, which is anteriorly deltoid, and the posterior-superiorly is trapezius. And these two muscles should be kept in mind when there is high-grade injury to the AC joint, because these muscles get disrupted with high grade of injury to the AC joint. About the movement, first 100 degree of abduction, there is no movement at the AC joint, but after 100 to 120 degree of movement of the abduction of the shoulder joint, there is gliding movement at the AC joint occur. So we can see in this video also, till 100 degree, usually there is no movement at AC joint, but after 100 to 120 degree, there is movement of the AC joint. About the mechanism of injury, this injury may occur because of direct force or indirect force. Direct force usually because of direct trauma to the shoulder, usually from a fall or in a contact sports. In this injury, mostly the arm is in adducted position, so that the force transmitted from the AC joint. An indirect force, there is a fall on the odd stretched hand, or there is flex elbow, so that the force get transmitted directly superiorly to the AC joint through the humeral head into the acromion, and that leads to injury to the AC joint. And this AC joint injury leads to biplanar instability. There is vertical translation as well as the horizontal translation, anterior and posterior translation of this joint also. So about the classification given by the Rockwood in 1984, which consider both AC ligament and the CC ligament. In type 1, the AC ligament gets stretched only. In type 2, either partial tear or complete tear of the AC ligament, but the CC ligament remains normal. There is no problem with this. So there is not much translation of the clavicle. In type 3, there is complete rupture of the AC as well as the CC ligament, and there is translation of clavicle also. In the type 4, the complete rupture of AC and the CC ligament, and the clavicle moves posteriorly into the trapezius muscle. Type 5, very high vertical displacement of the clavicle. And in type 6, the clavicle comes underneath the coracoid. Again, in this injury, in these three, type 4, type 5, type 6, usually there is injury of the deltoid as well as the trapezius because of so much of movement of clavicle. So we can see here in animation also, the injury of the AC joint. In grade 1, there is only a sprain. In grade 2, there is partial or complete tear. In grade 3, there is tear of the AC, CC ligament is also there. Type 4, clavicle move posteriorly into the trapezius fascia. In type 5, very high movement of the clavicle, and the shoulder scapula get depressed. And in type 6, the clavicle comes under the coracoid process. So in the physical examination, there is many tests for this. The most specific one is O'Brien active compression test, in which there is 90 degree of flexion at the shoulder joint and 10 degree of adduction, and the maximum internal rotation of the forearm. Then patient is asked to raise the arm against the resistance, and patient will have pain at the AC joint when there is problem with the AC joint is there. So let's see what happened there. So this is the position in 90 degree of flexion and 10 degree of adduction of the humerus. And in maximum internal rotation, GT comes under the acromion. And as the arm get elevated, forearm get elevated against the resistance, the fulcrum comes to the head of the humerus, and this get engaged over the acromion, and there is movement of the acromion that leads to the pain. This test also get positive when there is problem with the slap part, the long head of the biceps insertion over the glenoid. So this is a specific test for AC joint. The most sensitive test is the cross-body adduction test, in which the arm of the affected side placed into the maximum adduction, and again that leads to the pain at the AC joint. About the investigation, the first investigation is the X-ray, which is the AP joint. The look for the CC distance, coracoiclavicular distance, as well as the acromioclavicular distance. In AC joint, usually any difference more than 2 millimeter should not be accepted, should be taken as pathological in comparison to the normal side. And similarly, in acromioclavicular distance, this distance should not be more than 5 millimeter in comparison to other side. So next is the stress view, in which the wet cuff placed in both the hand of the patient and get the AP view of both the shoulder at the same time. This we usually not require in type 4, type 5, type 6, usually to difference between the type 2 and the type 3. Then the Janka view, in which the X-ray beam should be 10 to 15 degree tilted cephalic side, and the focus should be over the AC joint. The next is the axillary view. Usually it helps in assessment of the horizontal displacement. Like this, AP view of the shoulder joint having disruption of the AC joint, not very clear with the AP view, but in the axillary view, if you see, there is a displacement of the AC joint you can see there. So this axillary view is also very important for identification of AC joint injury. Recently, Bassmania view has been described. This is also called as medial stress view. And very early, the Alexander view was also the same view. This is the cross arm adduction view. So you can see this is the AP view, and this is the cross arm adduction view, in which you can appreciate the overriding of the clavicle over the acromion. So there is some associated lesion with AC joint also published recently. The concomitant lesion is almost 25%, in which the slap is the maximum 15%. Sometimes there is fracture of the coracoid also 5%, and the rotator cuff tear also almost 4%. So this was one of the case with AC joint dislocation. And there was the clinical test was positive for rotator cuff tear, so the MRI was done, and you can see there is a rotator cuff tear as well as disruption of the AC joint. So there is a scapular function disruption with the AC joint dislocation also, in which there is depression of the scapula, anterior tilting, and the internal rotation of the scapula happens. And this may lead to additional symptom that is not directly related to the AC joint. Like here, we can see this is a type 3 type of AC joint dislocation, but it's not very prominent because of hypertrophy of trapezius muscles. And the medial border, entire medial border of the scapula is prominent. So this is a pattern of scapular dyskinesia. That is one of the complications with AC joint dislocation patient. So about the treatment part, the type 1 type of injury usually treated with the sling for 1 to 2 weeks with ice and analgesic, followed by the shoulder strengthening exercises. In type 2, where there is partial or complete tear of the AC ligament, but CC ligament is fine, usually such type of injury is treated by the sling for 2 to 4 weeks, in which these ligament get completely repaired, followed by the exercise. In type 3, again, there is complete rupture of the AC as well as the CC ligament. So usually type 3 injury patient get treated with the conservative management for usually 3 to 6 weeks. But because of, and some patients get treated surgically. So this is the area of controversy for very long time. Recently, ISACO's upper extremity committee recently introduced the concept of subtype of type 3, type 3A or type 3B. In which type 3A is stable and patient get rapid improvement. There is no any sign of scapular dyskinesia, and in Basmania view, there is no any overriding. And type 3B is opposite to that. This AC joint is usually unstable. There is no improvement and sign of scapular dyskinesia, and Basmania view, there is overriding of the AC ligament, AC joint. And at the same time, Bitgel also published in Orthoscopy 2014 along with the ESACOS group. And this is the treatment protocol for type 3 injury. Usually for 3 to 6 weeks, this type of patient should be treated conservatively. And if there is no pain or function is full, then its non-surgical treatment should be continued and taken as type 3A. But when there is pain persistent and there is scapular dyskinesia, go for Basmania or Exzelander view. And if there is overriding, go for the surgical treatment, that is type 3B. But some patient will not have overriding of the distal clavicle and should be treated with conservative conservative treatment method. And surgery should be done only when conservative treatment should fail. About the type 3, about the type 4, type 5, and the type 6, when there is disruption of the AC and CC ligament, along with there is disruption of the trapezius muscle is also, along with in type 5, disruption of trapezius and the deltoid muscle is also. Similarly, in type 6, when clavicle comes underneath the coracoid, again, all these muscles get disrupted along with injury to the AC and the CC ligament both. Usually, the surgical treatment is recommended for this, but many literature is still showing very good result with the conservative management with this type of injury also. So again, the ESACOS committee along with this Bitgel says the treatment algorithm for the AC joint, in which type 1, type 2 should be managed conservatively. Type 3, initial conservative management. If conservative management fails, then go for surgery. Type 4, type 5, type 6, surgical treatment should be considered. And in the surgery, there is two parts, that is the AC ligament part and the CC ligament part. For the AC ligament part, there is K-wire, that is Femister method is there, no longer used nowadays because of migration of the K-wire even to the lung area. And the hook plate, very mechanically very strong construct, hook plate is there. Then the cerclage along the CC ligament, AC joint. And for the CC, there is both screw is there. If there is bicortical purchase of the coracoid, again, very strong mechanical construct. And there is augmentation of this part is there. There is complication associated with all type of surgery. In the hook plate, very good clinical result, but the complication is almost 10 to 22%. With vertical loss, acromion erosion, and sometimes maybe fracture, the stiffness, difficulty in abduction after 100 degree, and need for secondary removal, that is the secondary surgery. It should be removed in almost every cases, ideally within 3 months, but till 6 months it should be removed. This Bosworth screw, again, good clinical result, but complication associated with this like screw loosening, malpositioning, screw breakage, destruction of the coracoid, all these associated with this. 10-15 years earlier, synthetic graft was very commonly used for AC CC part, but currently this use has been rejected by many recent literature because of high failure rate with graft tear, clavicular osteolysis, and the redislocation. Now, recently, the main focus is on CC repair with the use of anchor, and so it's very good clinical result. Only problem is the pull out of this anchor, particularly those who are a smaller anchor, 2.5, 3 mm type of anchor. Those who are having 5, 5.5 or 6 mm of anchor with very good result. There is very high pull-out strength of that. And then there is button recently. This again recent advancement in CC repair. And this may be single strand or maybe double strand. That is, one is for the trapezoid and one is for the conoid part. But again, complication associated with this, like fracture of the coracoid, clavicle, and the tunnel widening. And recently in 2018, American Journal of Sports Medicine, the complication rate was assessed with all these methods for acute repair of the AC joint. The open suspensory method 25% around, the screw and the Oref method having high rate of complication this part. Again, the orthoscopic CC repair and the reconstruction, both if it is there, then 30%. Then the orthoscopically suspensory fixation is having 15%. Like this 16-year male patient having type 5 AC joint dislocation was treated with the orthoscopic CC ligament repair with the AC joint tightrope. You can see there is reduction is there, and in auxiliary view you can also see there is no anterior posterior translation of this ligament. And this after 3-month post-op period. There is little bit of tunnel widening is there. That is the recommended complication of this technique. But with this technique, this AC joint repair with the button tightrope, there is a risk for the horizontal displacement. Like here you can see this was repaired. There is no horizontal displacement, but here you can see there is a horizontal displacement of this posterior displacement of the clavicle is there. Though vertical displacement has been taken care, but the horizontal and posterior displacement is still there. So considering this complication, now recently there is a lot of literature regarding the combined treatment of both CC and the AC stabilization by multiple method have been described, like double tightrope along with the circlage along the AC joint. So there is a new trend about the address the deformity in the both the plane, that is the CC and the horizontal instability. So this will reduce the lateral as well as inferior scapular displacement, and this provide the better scapular rotatory stability. Like this patient having superior as well as the migration of the clavicle, horizontal migration is there, and this was treated with the CC ligament repair with the AC joint tightrope, and there is repair of the capsule because it was fresh, 1 week injury. So the repair of the capsule with the suture anchor was done. This for the AC joint. This is the biomechanical testing regarding all these methods. Finish the 5 mm cork screw with the 5-number fiber wire having very high strength. And the native ligament, CC ligament strength is 578 Newton. So bicortical Bosworth is again very good mechanical construct. And the tightrope is also a good construct equal to this, the native CC. But we were done having the lowest mechanical strength of ligament. So it having very high failure rate and usually done for the chronic AC joint injury. So chronic AC joint is usually taken after the 3 weeks. There is debate about this, whether it should be taken at 3 weeks or 6 weeks. So till 3 weeks, it's the acute AC joint. 3 to 6 weeks is subacute, and more than 6 weeks should be considered as the chronic AC joint injury. And the first surgical technique was advised for this, the coracoacromial ligament transfer. And the name is the Weaver-Dunn, in which there is excision of the lateral end of the clavicle. Then the detachment of the AC ligament, that is the acromioclavicular ligament, a coracoacromial ligament from the acromia, and transposition of this ligament to the distal end of clavicle. But considering high failure rate with Weaver-Dunn, the modified Weaver-Dunn was introduced, in which the transfer of the coracoacromial ligament to the lateral end of the clavicle. The CC ligament part was also taken care by either this tightrope or loop graft around this clavicle. This is the graft loop around the clavicle. So nowadays there is concept of anatomical reconstruction of the CC ligament as well as the AC ligament. So where you can see only CC ligament was reconstructed anatomically with the screw in the hole in the clavicle, or it get tightened over the clavicle only without making any holes. The loop of the graft is around this the coracoid. This is another technique when is the graft was looped around the coracoid and the hole was made in the clavicle, and the same graft was passed over the acromion so that the AC part was also get reconstructed and get supplemented with the fiber tape. Another method that taken care of this vertical displacement with the tightrope along with the loop around the clavicle. So in 2016, Spencer checked for the complication associated with the technique in the chronic AC joint. Units the modified we were done having complication rate 30%, and those who are having the synthetic button along with the loop, it was the yellow graph, we usually do with the autograph, the complication rate is 5%. So here it was the 6-week-old AC joint injury taken as the chronic AC joint injury, in which the tightrope was used to take care of the vertical displacement, and the 2 hole was made in the clavicle, and this graceless graft was passed the loop around the coracoid and passed in the clavicle and tied over the clavicle there. And this was the patient with the clinical picture having full abduction. This is after the 3 months of that. Then this is the full flexion also. And then there is full internal rotation. You can see both the side scapula looks normal. So recently in 2019, it was a systemic review and meta-analysis of the operative technique. Says the overall failure rate was 20%, and the overall pool complication was 14.2%. The most common was the infection, followed by fracture of the coracoid and the distal in clavicle. Hardware or button failure was 4.2%. So conclusion was there was no difference between the orthoscopic and open technique in regarding to the loss of reduction overall complication rate or revision rate. Open surgery has greater rate of clavicle or coracoid fracture than the orthoscopic surgery. Another recent literature regarding the revision AC joint stabilization in 2019, and almost more than 5,000 patients was studied. The overall complication rate varied between 5 to 88.9%. Evidence for revision AC joint stability is still lacking, and the adequate restoration of the native joint biomechanics, along with the optimum healing environment, provide the long-term satisfaction to the patient. Again, recent review in 2018 says there is no current gold standard for treatment. With recent advancement in the orthoscopic technique and the introduction of new equipment, the shifting toward the less invasive and more orthoscopic assisted method. However, results are still comparable to the more conventional method. And whenever an orthoscopic approach is chosen, the surgeon orthoscopic expertise probably play the most important role in achieving the good outcome. Thank you.
Okay, thanks, Arvind. So questions, especially
Sir, good evening. Sir, I wanted to ask that in type 1 and type 2 injuries, are there any evidences to show that a figure of 8 bandage or a clavicle brace is as good or is equally or is better than giving the patient an arm sling pouch?
Recent literature says the arm sling pouch is good enough for type 1, 1 to 2 week is maximum, and type 2, 3 to 4 week is maximum. Meanwhile, patients should do their isometric exercises from day 1, and after completion of the sling time, the active passive followed by active exercises.
So the figure of 8 bandage has never been a treatment for AC dislocation. Okay, so you do it for clavicle fractures, and even there is no evidence to show that it's better than a sling. What people used to use for the AC joint injuries is known as a Robert Jones bandage, which was a strapping with the AC joint reduced from the shoulder to the chest, okay? And that was really something that didn't work very well at all because the joint always subluxed. And so now that is more or less given up, okay? So I think the figure of 8 was never a treatment for a AC dislocation.
Sir, portal position क्या लेते हैं?
If you are doing orthoscopic AC joint reconstruction, so Wien portal is always the posterior portal, that is the standard one. But in spite of 30 degree, you need to use the 70 degree scope because the coracoid is the inferior to the level of the glenoid. So, and you have to see the base of the coracoid. For that, you have to use 70 degree scope. The rest portal is same.
And I think strictly speaking, we shouldn't call it arthroscopic, but endoscopic, yeah?
Yeah, because it's not the joint. So
not actually going into a joint. It's like your endoscopic carpal tunnel release, etc. Okay.
Okay, sir.
Any other question?
सारा तो discuss हो गया, sir.
Sir,
Hey, so, okay, so I'll ask you a question since you know everything.
No, sir.
Okay, so I have a patient with a type 3 injury who comes to you in the emergency department. Okay, he's a sort of physically active person.
Yes, sir.
How will you treat him?
So physically active person, that means the higher demand he has, and type 3 injury are the first. Investigate for the AC joint. After investigation, if there is a type 3 injury, sir, first we treat according to sir told conservative first trial for 3 weeks. After that, sir, if the patient complaint relieved or not relieved, if relieved, then continue conservative. If not relieved, then additional X-ray are done. And if there is overriding or overlapping of the clavicle, we go for surgery.
So what is your conservative treatment?
Conservative treatment is sir arm sling pouch, sir, along with the physical therapy followed by the passive range of movement followed by the active range of movement, sir.
So what is your physical therapy?
Physical therapy, I mean, sir, rest in arm sling pouch followed by movement, range of movement, first passive, then active.
So when you say followed by, how many days are you talking about?
Exact, I don't know.
So how do you plan your treatment?
Sir, a passive range of movement when patient tolerate as still patient tolerate pain. After that, active range of movement, so 1 to 2 weeks of the passive range of movement, and after 2 weeks active range of movement, sir.
So in 3 weeks, how do you decide that he needs surgery?
After 3 weeks, sir, as I told, additional X-rays we use.
So these are just some guidelines, okay?
Yes, sir.
Yeah, so you need to have a plan of your own. Okay?
Yes, sir.
So I think type 3 injuries is a controversial area still.
Yes, sir.
and the difference between 3A and 3B is something that is a recent sort of classification, which may tell you which ones of the type 3 need surgical treatment.
Surgery. Yes, sir.
Okay? So I think you must have, if you say conservative treatment, it just doesn't mean, you should also know what you're going to do in the conservative treatment. Okay. So range of movement, if it initially will be painful, okay?
Yes, sir.
So you have to wait for pain to subside before you can start range of movement exercises.
Yes, sir.
Yeah, and
And then-
meanwhile, patients should do the isometric exercise of the muscle around the shoulder joint, because
and also physical therapy includes things like ice packs for swelling, etc.
Yes, sir. Painkillers.
Analgesics, whatever. Yeah.
Sir, I have one question regarding when you are doing tightrope treatment by open procedure or when you are doing it endoscopically. What is the difference between these two, sir, on the means during the approach and the muscle damage and all?
So by orthoscopic mean, you see better the base of the coracoid. That is, you are not seeing the base of the coracoid by open method. You are seeing just retracting the muscle and coracoid is in front of you. So by orthoscopic mean, you see from the inferior side the complete base where it get inserted over with the bone base, and you may see complete diameter of the coracoid, and then you make the drill hole in the center through the jig. By open method, many part you see the base, but it's not like whatever you see with the orthoscopy. And the second thing, you have to erase some the deltoid attachment around the clavicle when you do by the open method. So that part you get escape with the orthoscope method. But again, with the orthoscopy, the passing a guide wire into the center, it's not very easy task until unless you are not very convenient with the system and you are not very used to with this. Then the guide wire in the coracoid get eccentric, or when you put 2 to 3 holes in the coracoid, then the chances of fracture is very high with this orthoscopic mean. So that part you get escape in the open method. In a single shot, you can be in the center of the coracoid. But
So
again,
Arvind,
yes, sir.
Sorry, no, can complete. Have you completed?
Yes, sir.
Okay, so you kept saying that the Bosworth screw is a very good treatment or a very good fixation, but why don't we use it?
Sir, if it is bicortical and in the center of coracoid, its mechanical strength is very high. It's mechanically very strong. The problem happen with this technique is it's not always bicortical, sometimes unicortical only, get oblique into the coracoid, not always in the through the junction of the base and body, sometime in the tip of coracoid. So in that case, it's not so strongly mechanically that much not so strong. So their problem happen. There is loosening of the screw happen. Sometimes fracture of the coracoid is also happen. So all these complications associated with this technique. That's why nowadays people is not using very frequently.
So it's a technical problem, not a problem with the method.
Yeah, it's the technical problem. It's done properly, then it's very good method.
But you're not dealing with the ligaments.
Not dealing with the ligament.
Just putting a screw through a bone, and how do you expect the ligament to heal?
Yeah. So in acute cases, they say the ligament get healed.
Get healed.
Done in 3 weeks.
For chronic ones, it's not going to help.
No, in chronic one, it's not recommended.
So for chronic one, it is tightrope and ligament reconstructions.
In chronic one, there is lot of technique is there, but all the technique says the biology should be used. So graft should be used in all the cases. And secondary, what you want to use, that's vary. Some person use anchor only, and the thread pass through the clavicle along with the graft through the base of the coracoid, and some just tied over the clavicle, and some make 2 drill hole in the clavicle and pass the graft. Some use tightrope there, and some use suture anchor to get roll, and somebody just roll a ethibond or fiber tape around the base of the coracoid and into the clavicle.
So you have to augment a biological fixation with some kind of mechanical fixation, both.
Yes.
Okay. Because
And sir,
chronic injuries, yeah.
One book has given type 7 injuries, sir.
Yes, there is further extension of this also, and still this classification needs to be revised at some part, because this don't deal with horizontal displacement too much that is associated with the vertical displacement, and it was written in the book of Rockwood, and it was never validated till now. So yes, there is a lot of other 2-3 classification is also there, but most commonly used classification is this classification one.
Rockwood
Yeah.
का 7th classification सर एक book में था सर कि AC joint along with the sternoclavicular joint का dislocation.
Yeah, there is extension to this. There is 2-3 extension to this Rockwood classification into the literature is also there.
So in that case, sir, what would be treatment, sir?
So that case is the floating clavicle, and it should be fixed at both the end.
Okay, sir.
okay, sir. So when we say that CC fixation means coracoid ligament fixation is one is rigid type, what you told with the metal, and non-rigid type is ligament and the synthetic graft. So we can say that non-rigid management is better, sir.
Literature don't say it's
Not yet. There's no evidence as yet, but I think the trend is towards
non-rigid.
Yeah.
And one more thing, in conservative management, taping is described, sir, in few papers like KT tape and all. So like Robert Jones sir told, it's taping for 3 to 4 tapes. They used it for that one. That is also.
So taping is used mainly around the joint for any type of joint when there is a sprain of the ligament, grade 1 or grade 2 tear, not the complete tear. So it's for any joint, ankle, knee. So for the AC joint also, if it is grade 1, grade 2, or maybe for grade 3, the taping can be done.
Okay, but when you are using it, sir, it will with the arm sling.
Yeah, it's basically taping prevent the excessive movement at the joint level, and at the same time you should give arm sling also.
Only problem was that with the original things like leucoplast and stuff like that, a lot of them had skin problems.
Yes, sir.
Okay, and so that was an issue. I think now you have some modern adhesive sort of things which don't cause those problems for taping, and which are used. If you see all the tennis players and other sportsmen, they have these fancy looking things which they put on, which work as well without the problems of the adhesive that you have in the conventional things.
Yes, sir.
Is there a role of the ligament repair itself in the acute cases?
Yes, there is.
Yeah, so that's what.
Yeah. Sir.
So AC ligament is repaired. The problem is you need to repair it to the bone. You rarely get good tissue on either side of the joint to suture it back properly. Okay.
The other ligaments are the coracoclavicular.
Again, similar thing. It's the mid-substance tears are not going to heal very well unless you have some kind of
supplementation.
Yeah, I mean, with supplementation, is there a role of repair with supplementation? Can we see them so well that we can take the bite through the coracoclavicular ligaments?
Yeah, a couple of literature is there, says the suture anchor they use over the coracoid, and they drill hole into the clavicle and then suture the thread. Then at the same time, they suture the CC ligament also. So if you can see very well this ligament, then you can repair along with the supplementation with the suture anchor.
Sir, I was going through one journal, sir. There are few cases of clavicle fracture with AC joint injury. In that case, sir, there are always described as double plating. So this technique of tightrope cannot applied after putting the plate on over the clavicle, sir? Or
So one case we have surgically treated here also. There was problem with the fracture of the clavicle along with this CC ligament injury. So you just stabilize the lateral end of the clavicle fracture with the clavicular plate. And nowadays the Arthrex company is having this plate in which you can pass this coracoclavicular CC ligament part with tightrope. That tightrope can be passed through that plate. But mostly cases when there is fracture, if you simply stabilize with the plate, that is lateral in clavicle plate, with very good amount of a screw in the lateral in part, that get treated. So
if you can heal the fracture in a correct position, the ligament will sort of heal itself, because these ligaments are just holding the clavicle. And so if your AC joint is okay, if the fracture heals, it takes care of it. Okay. So the question is getting adequate stability, because all these lateral end fractures which are displaced, where the proximal fragment has gone up quite a bit, they have coracoclavicular ligament injuries. Okay. But here, if you can get the fracture to heal, it's okay. The problem is if the fracture doesn't heal.
yeah. Yeah, and in trauma, whenever there is trauma and problem with the ligament, the chances of healing, primary healing of ligament is very high because of lot of growth factor and healing factor in case of fracture.
As long as the fracture heals.
Yeah.
If the fracture displaces, then your ligament is also gone. And those used to be a problem before we had the newer plates, because the lateral end was very difficult to get adequate fixation on. And the other option is to use a hook plate, which is kind of a indirect way of keeping the middle part of the clavicle down to the level of the AC joint. Yeah.
So my question is, what is your indication of still using the hook plate, sir?
So if a very lateral clavicle fracture where you can't get adequate hold in the distal fragment.
Right.
Okay.
and sir, one question regarding in Beaver-Dunn procedure, you told there is you remove the lateral end of clavicle. So that is a part of the approach, sir?
Yes, that is the part of the approach. Around 5 mm of clavicle should be removed. But again, some literature come up that you should preserve the clavicle as much as possible. But in Weaver-Dunn procedure, around 5 mm of clavicle was excised, and this coracoacromial ligament get transferred into the lateral end of clavicle. That is the excise.
So in the Weaver-Dunn procedure, you have to excise it because you actually pass the ligament into the clavicle, intramedullary into the clavicle from the lateral end. Okay. So unless you remove a part of it, that's not possible, or the joint. So in the later cases, the joint has become irregular anyway. Huh?
Yes.
So they say that there's no point preserving it. And now, how late is too late is a different question. We don't really know the answer.
And sir, in this sense, sir, when you are putting tight rope, how much far it is from the lateral end of clavicle, that hole, drill hole, what you make, because that is anatomical, sir?
Yeah.
Anatomical reconstruction?
Yeah, and also if you are using the twin tightrope, means there is 2 button over the clavicle and 1 button over the coracoid. In that case, the one drill hole should be around 2.5 centimeter from the lateral end of clavicle for the trapezoid part, and another drill hole should be at 4.5 centimeter for the conoid part. And if you are using single hole for single button over the clavicle, then it should be in between 2.5 to 4.5, around 3.5, 3 to 3.5 centimeter from the lateral
And
end.
in the center of it.
Okay, and anteroposterior center of it.
Yeah.
If it's single, otherwise, if it's double, you'll put one slightly anterior, one slightly posterior.
Yes.
And over the clavicle, it is at center, sir. Base of the coracoid.
Yeah, in the base of the coracoid, try to be always in the center, because the chances of fracture increase as you become eccentric in the coracoid.
And you are putting patient in V chair position, sir. So how you take the X-ray means fluoroscopy when you're doing.
So your shoulder should be out of the table, and then your image can come and take the view. And this position is very important when dealing with the AC joint, because intra-op it looks reduced, but when you do X-ray, it shows it's up. So today what we have done that just stabilize the AC joint with the K-wire first, then followed
that is semister what you explained.
Yeah.
With the K-wire.
K-wire is to just keep it reduced while you're doing the...
Yeah, while you are doing this tightrope part.
Otherwise, to judge the exact position you want to tighten it to becomes difficult.
Yeah, and also load over the tightrope is very high when the clavicle is very much up. So that load is also get reduced. So you don't need to put don't need to pull very hard the tightrope from the base of the coracoid.
Also, because we also repaired the acromioclavicular ligament, that adds as an additional sort of stress reliever from the tightrope.
Sir, one question out of this topic, sir. What is femester bone grafting technique, sir?
GT.
So basically, it's done for the non-union of the long bone. Basically, for the tibia, it was described. So that time there was no fixation. So mostly just you separate along with the periosteum, particularly in the posterior lateral part, and put lot of bone graft there, and then suture again back, cover the bone with periosteum and the muscle completely. Am I right, sir?
One described for that neck also, greater trochanter, from the greater trochanter it is taken.
The concept is bone graft should be intraperiosteal.
Yeah.
Okay.
So whenever you're doing decortication for anything, the idea is that you try and keep the periosteum and muscle attachment to that part intact and go underneath that. It's not always possible. Now the femester for the fibular non-union actually was a posterolateral approach, okay, where you decorticated the tibia from behind and you put in your graft at the back, okay?
Yes, sir.
Which is, there's another, that procedure's got another name also, no? So there's one where you actually try to unite both the tibia and the fibula, huh? What's that procedure called? That's called
Huntington's?
Huntington's, yeah.
So I think we have most of the question, whatever confusing one we have discussed, sir. And if DNB have any questions?
Yeah, I think we should.
So recent advances question, sir. Topic.
Advances in what?
Sir, all possible topics, sir.
So that can go on forever. Okay.
Orthoplasty, arthroscopy, pediatrics, trauma.
Yeah, so I think each area you'll have a different thing, okay?
Yes, sir.
I think
Previous
I
year,
have,
sir, it was asked recent advances in clavicle fracture management, recent advances in thoracolumbar injury management.
Yeah, so I think each of these you'll have to, the idea in these basically are to catch up with the modern literature on it. Okay.
you should have a
Yes.
proper journal club every week. And then,
So
Unfortunately,
maybe can make easy for Gautam. You just remember all the surgery, whatever done here.
most
Yes,
of it
sir.
is.
Yeah, that is almost the recent advancement. Whatever you ask for, like clavicle fracture, you said. So lateral in clavicle is the recent in that. So similarly, like in this AC joint, this AC joint tightrope is the recent one, along with the repair of the AC capsule and ligament is the recent advancement in this. So all
Yes,
the
sir.
treatment
you keep in your mind, whatever you have saw here.
So ankle, you can talk about posterior malleolar fixations. Okay. Similarly, for
Okay.
proximal tibia, you can talk about posteromedial, posterolateral fixations. So every area there's OFA, you can talk about what are the newer trends in terms of it. Neck femur, you can talk about the various screw configurations and the newer plates that have come in. Okay.
Yes, sir.
So you can talk about medial buttress, the BDSF, which is the sort of biplanar double this thing fixation. Then you have the newer things like the FNS, which is the femoral neck system from the synth AO, and then you have the Targon plates, and you have different other plates. You have the replacement of the partially threaded cannulated screws with fully threaded screws after you've done your compression. So the aim is there to prevent excessive collapse in the neck fracture, which is a problem. So I think each area you can, if someone asks you a general question for recent advances, you break it up into the different areas and start writing about that, and you'll never finish the answer. So plan out what you, I think they may ask in a particular area, not about.
Yes, sir. Yes, sir. Particular fracture or particular condition, sir.
Yeah, so you can talk about the variable angle locking plates as opposed to just monoaxial locking screws. Okay.
Yes, sir.
You can talk about also about flexible locking. Okay.
Sorry, sir.
The flexible locking screws where you're only the distal part is locked, and so the screw holds the plate and the distal cortex, not the proximal, the near cortex. Okay, so the motion lock, as they call the Zimmer one, the AO one was called something else, but it's not yet come out because there were some problems. It was called the dynamic locking system or something. Then you have interlocking locking nails, multi-directional locking nails for the distal femur.
Yes, sir.
Okay, so all these things. Then you can have supracondylar nailing for the tibia and
Yes, sir.
for proximal and distal tibial fractures. So all these things are happening here.
Yes, sir.
Okay, so I think most of the then you have anatomical plates for the foot, the talus. Okay, so that also we've used.
Yes, sir.
So tightrope for syndesmotic injuries, though there's still some controversy about that. But I mean, there's no clear evidence, but definitely it's one of the newer trends. Then total knee solutions is the new thing that we are talking about, where you deal with the as not all the, but some of the ligamentous injuries at the same time as the bony injuries. Okay.
Sir, something bicruciate retaining total ni ऐसा कुछ आया.
So ACL, PCL.
Yes, sir.
Yeah, recently launched this bicruciate returning the total knee replacement. Again,
So most of those probably don't need a knee replacement. Huh? I mean, so it's probably stretching the indications of the knee replacement. I mean, so I think, so everything new is not necessarily an advancement. Huh?
Yes, sir.
So you can talk about how surface replacement of the hip, metal on metal resurfacing has failed. Many of the unicondylar knees have not worked very well. Some of them have, some of them haven't. So every area has something new coming on. So you start making a list of each of these and then pick out the 3 or 4 things you think are important and prepare on them. Okay.
I think while reading each fracture, we should write recent advances with that fracture. So it's easy to remember also. While and revising the examination during the examination. So, regarding this one, sir, few things, but I have read in the journal one term, what is surgery leak, what they have used, one paper on that surgery leak, what they have used is that these synthetic ligament, what we are using like tightrope and all, this is also called as surgery leak. Initially used for revision and now they are using it as a primary fixation.
So tightrope is not necessarily a synthetic ligament, okay? There are synthetic ligaments, LARS and things like that.
Okay.
Not recommended nowadays. Very strong evidence that it.
So there's some carbon fiber things which are coming back into vogue in a different form, but still not even. So then you can talk about biodegradable fixation. That's another area where there are new things coming up about, where less likely to cause foreign body granulomas, etc. with the newer material.
Yes, sir.
Okay.
I think, sir, what you're telling is regarding the synthetic ligament, which is used for scar formation, scar tissue formation over it. So it acts like that. Something also like that is used before, sir. So some scarred tissue is formed and which works as some hold over that, sir. Please.
I'm not sure what you want, what you're talking about. I mean, yeah, so most of these work, so these carbon fiber things, that's what they do. It's not as if they act as a true ligament, but I think most of them have not so far been that successful, okay? Except for some enthusiasts who use it, it's not got generalized acceptance in most places.
Because I have checked, sir, only 1 or 2 paper for everything it has come up. Then again, there is nothing over there.
So you should remember Scott's parabola. Huh? So you know what Scott's parabola is?
Yeah, it's going up then coming down.
So for any new technique or this thing, it goes through a process where initially there's an initial research, this thing, then suddenly there's an enthusiasm for it, and then you start seeing the complications, etc. And then it comes down, or it becomes a accepted method of treatment if it's working. So a lot of things go through that and then come right down again. Okay, so I think we should stop now. It's already 6:30. Thank you, Arvind.
Thank you, sir,
so much, sir.
for the opportunity.
Thanks. Okay, till next week.
Yeah, thank you, sir.
Thank you, sir.
Thank you, Arvind, sir.
Thank you.
Thank you, sir.